What's the difference between treatment of gingival recession around teeth and gingival recession around implants? First of all, we will cover the topic of treatment of gingival recession around teeth, and then we will speak about implants. But both of them have an objective. In the case of teeth, the objective is to cover the cement enamel junction and to displace the soft tissue margin in a more cornered position with respect to the cement enamel junction. In the case of implants, there is no cement enamel junction. So in the case of implant, the objective is to replace the soft tissue margin in the aesthetically ideal position. What is the aesthetically ideal position? Depends on the tooth you are treating. If this is a lateral incisor, it should be shorten the position of the soft tissue margin with respect to the corresponding central. So the level of coverage depends on the ideal position of the soft tissue margin, and this is what you have to achieve with the covering procedure. Complete coverage at the level of the implant means replace the soft tissue margin at the level of the ideal position of the soft tissue margin of the implant-supported crown. If there is an homologous tooth, natural dentition, it means that the soft tissue margin should be placed at the same level of the gingival margin of the homologous natural tooth. So it's not only the metallic, it's not the implant that has to be covered, but it's the crown. I have to place the soft tissue margin, this is a lateral, more corner than the ideal position of the gingival margin of the central. So there is about 3 millimeters of crown that has to be covered in order to achieve the complete coverage of the implant-supported crown. And we will see how big is the problem of the crown, because the great majority of the implant which has recession is because there is a mistake in implant installation. This implant is placed too much buccally or with a bad angulation. And most of the people say, oh, I have a recession of this implant because there is buccal bone loss. It's not true. It's not true. You have a recession because being the implant placed outside of the bone, because of the mistake, obviously the crown, implant-supported crown, will be even more buccally than the implant, yes or not? And obviously, how can the soft tissue margin remain stable at the level of the implant crown if the crown is so buccally displaced? There is no how. So the reason for the gingival recession is the bad implant installation, because the buccal displacement of the implant makes the crown even more buccally, so there is no soft tissue thickness enough that can be maintained stable in that position. So the first step will be removal of the implant crown. That's something that makes completely different the area that we have to cover. It's not the crown anymore, but it's something that is much more palatally displaced, and so we can improve coverage with respect to what we can achieve if we leave the implant-supported crown in position. But this is something that we will cover after understanding what can we do first at the level of the teeth. You cannot treat any implant if you are not able to treat soft tissue management around teeth. When you see a tooth that has recession, first of all, you have to see if what you want to achieve is achievable. What does it mean? It means that you want to displace the soft tissue margin more corner than the cement enamel junction. But the problem is, first problem is, do you have the cement enamel junction in this tooth? Because when you look at the tooth, especially if you look at the profile of the tooth, you immediately realize if the enamel is continuous or it's interrupted. If the enamel is broken, because it doesn't exist a tooth whose enamel is sharply interrupted. So if you don't see the continuity of the enamel from the starting point, cement enamel junction, to the end point, which is the incisal margin, it means that there is loss of enamel together with some recession of the gingiva. If there is loss of enamel, this loss of enamel has to be treated first. Because, first of all, if you leave this enamel broken, the only thing that you have to do is to advance your flap more coronal with respect to where the enamel is broken in order to compensate this gap. But if the flap shrink a bit, it collapses. And so there is no way to give stability to a flap that is placed too much coronal, because if you place the flap more coronal than where the flap can really stay, it will shrink a bit and then collapse. So from a surgical point of view, it's absolutely necessary to restore the continuity of the enamel. So when we advance a flap, we will advance on a surface very convex, very clean, into which the flap, even if it shrink a bit, it don't collapse. That's very important. The second reason is because if we have to make a restoration, we cannot make after covering the root. Because if we have to make a restoration, we have the whole root that is now available for the clamp application, rubber dam isolation, so we can make our composite restoration for restoring the cement enamel junction very, very effectively. And we know that adhesion mainly depends on the capability we have to isolate the field. While if you move the tissue closer, we don't have the area into which we can isolate anymore, and so we cannot restore the tooth after. So the reason why the tooth has to be restored before are two. First of all, surgical. We need a surface onto which we can apply your flap with no risk of shrinkage and collapse. Second one, it's clinical. We want to make a restoration in a very, very good isolated field where the clamp is applied into the root, the rubber dam is applied, and so we can make the restoration. How should this restoration be made? It should be done by restoring the right emergence profile of the enamel with respect to the root. And we have the adjacent teeth, we have the contralateral teeth, in order to see, by the restorative point of view, which is the best way in order to restore this enamel back. And if you look carefully and if you compare the before and after restoration, you see that most of the time when you have abrasion defect that is very, very deep, we also have to change the shape of the enamel by reducing this triangular area of enamel in excess in order to reshape and being able to make the end of the composite restoration not too much apical, which means increase too much the length of the crown, but at the same time very, very gently convex. This removal of the enamel in the most buccal aspect of the abrasion defect is called enamel plastic. So most of the teeth with deep abrasion defect has to be treated in order to restore the very, very natural convex shape of the enamel, like the anatomical cement enamel junction, cannot be restored only with composite restoration, but also with enamel plastic. Because if I want to give to the enamel the natural emergence profile, keeping this amount of enamel abrasion defect, obviously I have to go very, very apical in order to give the uniform convexity. Do you understand what I mean? While if I want to make the composite restoration, so the new cement enamel junction, in the most aesthetic position, which is about 1 millimeter more apical with respect to the cement enamel junction of the lateral, because what I would like to have is a canine that is just a bit longer at the level of the soft tissue margin with the corresponding lateral. For sure, I have to change also the shape of the enamel. And to change the shape of the enamel means to make enamel plastic. Making enamel plastic allows you also to improve the blending of the composite restoration with the remaining enamel and make the finishing line of your composite restoration in the most aesthetically guided position. So where the restoration is finished is in relation to the position of the cement enamel junction of adjacent teeth following the aesthetic rules. Now that I have the right shape, the over-counter of the enamel with respect to the root is very, very similar to the adjacent teeth. We have to make the surgical procedure. And when you make surgery, the root is planned. Why? Because the old dentin that was demineralized, that was contaminated, must be removed until very, very hard, smooth quality of dentin is achieved. And this makes the concavity that you left at the level of the root sometimes even deeper with respect to the convexity that you create with the composite restoration. In order to compensate the concavity of the root with the convexity of the enamel, we have to apply a very, very thin but good layer of connective tissue that don't allow or allows the flap to remain stable to cover the enamel. And in the case the flap shrink, this barrier, which is represented by the connective tissue graft, will prevent the flap to shrink and to collapse in the concavity that was left at the level of the root. So the indication to use a connective tissue graft in the treatment of gingival recession around teeth is in relation to two main aspects. First of all, is the amount of keratinized tissue remaining in your flap. Why? Because the flap is advanced during the advancement of the flap more coronal than the cement enamel junction. Yes, because we want to cover more, because we know that some shrink will occur. So if I have a recession, I will displace my flap more coronal than the cement enamel junction, so to prevent that in the case of shrinkage, the root is exposed. Do you follow me? Okay. So if in your flap you have only 1 millimeter of keratinized tissue remaining, yes, this 1 millimeter will be placed on the enamel. Okay, so the tissue that is remaining to cover the root is only alveolar mucosa. And the alveolar mucosa is extremely light, extremely thin, and it will collapse on the root, especially if there is a concavity. And this risk of collapse of the alveolar mucosa into the concavity of the root is compensated by adding a small layer of very, very dense collagen-rich tissue that is taken from the palate that prevents, from one side, the flap to shrink and the alveolar mucosa to collapse. But this is in relation to the amount of keratinized tissue you have in your flap. So if I have only 1.2 millimeters of keratinized tissue, this is placed on the enamel. And so it's only alveolar mucosa on the root. So this is an indication to add a connective tissue graft, because the alveolar mucosa is not capable to be maintained separated from the concavity, but it collapses because it's very light, very, very thin, and not good collagen-rich dense, like the keratinized tissue. If I have 3-4 millimeters of keratinized tissue, yes, one will be displaced on the enamel, but the remaining 2 or 3 in the root, that's good because it's stable. But if I have only one, this is placed on the enamel, what is remaining on the root, it's only alveolar mucosa, it has to be compensated from the risk of collapsing. So what is the first and main indication to add a connective tissue graft? Lack of keratinized tissue. Second, even if there is keratinized tissue, but there is a big concavity, very, very soft root, demineralized root, you have to apply the connective tissue graft, even if you have keratinized tissue, to prevent the collapse of the tissue, because the root is not adequate for keeping the tissue in the right buccal position. Then this graft, which is placed at the level of the root, while the keratinized tissue is placed at the level of the crown, integrate each other. The connective tissue of the graft integrate into the connective tissue of the flap, but from an external point of view, an aesthetic point of view, you will never see graft exposure. And so you will never see any difference in color, texture, and surface characteristics, because you don't know how this graft will heal if you leave it exposed in terms of color, surface characteristics. Furthermore, if you leave it exposed, you have to take it thick because you don't know if it survives. While if you cover it, it's not the graft that makes the thickness by itself, but it's the combination between graft and flap that makes the right thickness of the tissue. And so the risk of losing thickness in the graft when it's left covered is very, very low with respect to the risk of losing thickness where the graft is left exposed. So in this case, the thickness of the graft can be really minimized, 0.5, no more, because we combine thickness of the flap plus thickness of the graft, and we don't lose thickness, but on the opposite, these two thickness, graft and flap, continues to increase thickness even years after the surgery. What about the apical dimension of the graft? Do we need the graft to cover the root? No. We need the graft to compensate for the lack of keratinized tissue, yes or not? The reason why we use the graft is not because we want to cover the root with the graft, but because the graft, the keratinized tissue is not good enough and we want to increase it. So the apical dimension of the graft is not in relation to the depth of the recession. If the recession is 10, I don't take 11, 12 millimeters of graft, because this is due, say, if you think that you are covering the root with the graft. While I will take a graft whose apical dimension is that one I would like to have in terms of keratinized tissue of the flap in order to give the flap stability. How much is the good amount of keratinized tissue you need into the flap in order to say, yes, I can use the coronal advanced flap with no graft? At least 3. Yes, at least 3, which means 1 on the crown, 2 on the root. At least 4 is even better. 1 on the crown, 3 on the root. How much graft do we take today? 4 millimeters. Apical coronal dimension of the graft is 4 millimeters, even if the root is exposed for 10. Because it's not the graft that is covering the root, but it's the flap. But the graft helps flap stability. And it is used to compensate the lack of keratinized tissue of the flap. This completely changes your way of working, because even if you have very, very deep gingival recession, the amount of graft you take is no more than 4, always. And the thickness of the graft is no more than 0.5, always, because it's not the graft that is covering, but it's the flap. And the graft is only used to give stability to your flap. With time, flap and graft integrate to each other and give an increase in the soft tissue thickness, which is much more than the calculation of graft plus flap thickness at the time of the surgery. So the increase in the thickness you have after years is much more with respect to the thickness you have at the time of the surgery if you add the thickness of the graft to the thickness of the flap. If the thickness of the flap was 0.5, the thickness of the graft was 0.5, I expect to have a thickness of 1. No. After 3, 4, 5, 7 years, I have a thickness that is even more than 2. So there is a synergistic capability of this graft to increase in thickness with time. And how can we interpret this outcome? Most probably, it is because the type of graft I'm using comes from the very posterior palate, immediately below the epithelium, because I make a free gingival graft that is desepithelialized extraorally. So the connective tissue I insert there is very, very poorly vascularized, very, very superficial, very, very posterior in the palate. And the graft from this environment, where it's very poorly vascularized, is taken to the buccal aspect under a flap made of alveolar mucosa only, extremely vascularized. And in this different environment, the graft continues to increase in thickness even years after the surgery. So the tendency today is to minimize the thickness of the graft at the time of the surgery, not to experience an excessive increase in the thickness with time, which is exactly the opposite problem we had in the past, in which we wanted to make thick graft because we were afraid about the risk of losing some of this thickness. So we really changed completely the surgical procedure once we understood that is the flap that is going to cover the root, giving stability to the surgical area, and the graft is only used when the flap itself don't have enough keratinized tissue. How is the key point of this flap? This flap has to be advanced coronally, more coronal with respect to the cement-enamel junction, because the soft tissue margin has to be displaced on the enamel. So the stability of the soft tissue margin on the enamel depends on the blood supply that the surgical papilla receive once they are advanced coronally above the anatomic desepithelialized papilla. So we have one concept to introduce, and it is the concept of the surgical papilla. Surgical papilla is the papilla you personally elevate with your blade that will be placed above the papilla that you leave, that thanks to the removal of the epithelium will be desepithelized and provide you the connective tissue bed for the first intention wound healing of the surgical papilla above it. So the papilla that you are elevating is called surgical papilla. The papilla you are desepithelizing is called anatomic desepithelized papilla. That is the concept behind the coronally advanced flap. And how is this papilla elevated? Obviously, generally speaking, it is a split thickness elevation. But split thickness is a general term that don't tell you nothing in truth. So I have to give you few words in order to understand how this split thickness papilla is elevated, in order to understand exactly what I mean. First of all, I sign my incision line with the bleeding line, which is only the minimum penetration of the blade in order to make the tissue bleed. In this bleeding line, I will insert my blade oblique. This is called bevel horizontal incision. Bevel horizontal incision. Only the tip of the blade is inserted in this line. And once I reach the mesial angle, I can immediately turn the blade, make it completely parallel to the external surface, and cut along the mesial angle of the recession, so that by keeping the blade parallel to the external surface, I calibrate the thickness of the papilla at this angle. So when you elevate a papilla split thickness, as I mean, it means that in your brain, you want to get with your blade as soon as possible parallel to the external surface, not parallel to the bone. The bone can go palatally. You don't care about the bone. I just care about the external surface, and I want to keep the blade parallel to the external surface as soon as possible, and I use the vertical release incision in order to keep the blade parallel to the external surface, and I continuously check the movement of the blade from outside, but never looking inside, until an imaginary line that is connecting the most apical extension of my gingival recession to the vertical release incision is reached. This line, it's called base of the surgical papilla, will allow the papilla to be turned up with no need to make the blade ever inside the probing pocket depth of the buccal aspect. So This is called blind incision because the incision is done checking the movement of the blade from outside in order to keep always the blade parallel to the external surface. And it is done in different steps. First of all, we bevel the horizontal incision. Then we reach the medial angle. This is the first time in which you can turn the blade and with the tip get parallel to the external surface. Once the papilla has been elevated in the most coronal aspect, you can keep the blade parallel to the external surface using the vertical release incision and the intracircular incision in order to keep always the blade parallel until you reach the most apical extension of the gingival recession. It's an imaginary line connecting the soft tissue margin to the vertical release incision, and now the papilla is completely elevated, split thickness. And the thickness of the papilla is not in relation to the thickness of the tissue. It's in relation to your decision to keep the blade parallel to the external surface. So even if the bone is here, or even if the bone is much more palatally, the thickness of the papilla should be the same. So you are not influenced by the position of the bone when you make split thickness elevation of the papilla. Otherwise, sometimes in the tooth, you can make a thin papilla, but when you're treating implant and the bone is not there, you take a papilla that is so thick that this is not our topic. If the papilla is too thick, there is no tissue enough for advancing the papilla in a more coronal position. So this is the story of the split thickness elevation of the papilla. Now there is the story of the disepithelialization of the anatomical one, which is the vascular bed onto which you apply the surgical papilla. And how can you prepare the vascular bed? First of all, you have to sign the area that has to be disepithelized by increasing the length of the vertical release incision until you reach the adjacent tooth. Now you place the blade completely parallel to the external surface, but now you cut between the epithelium and the connective tissue. So you are much more superficial than here, because here I use the bevel, remember, in order to give to the surgical papilla epithelium and connective tissue. While here, I don't have to bevel anything because I get into the first elevated surgical papilla area. I cut between the epithelium and the connective tissue, separating it with the blade. It's only the blade, the only instrument that can be so precise to cut between the epithelium and connective tissue. But the blade is also not capable to get to the tip. The blade is capable to disepithelize the base of the papilla only. So now you ask your assistant to come very, very close to the tip of the papilla with a suction. And from the suction, the air coming from the suction is more than enough to turn the epithelium once it has been separated from the connective tissue at the base of the papilla. So now I'm already completing the separation of the epithelium from the connective tissue at the base of the papilla. And you see that I give the epithelium to my assistant suction that keeps it separated from the connective tissue. So I can change the instruments, and I use the microsurgical scissors, which is very, very small in tip, that can be applied on the connective tissue surface, which was previously prepared with my blade. And now I can continue this cut until the most coronal tip of the papilla, even if very, very small, very, very triangular, is reached. The only instrument that allows you to complete the disepithelization of this triangular to the tip without cutting the tip, but at the same time removing the whole epithelium from the tip, is the microsurgical scissors. So the disepithelization of the papilla is a very, very important phase of the corneal advanced flap surgical procedure, and it is done, first of all, identifying the area to desepithelize, then placing the blade parallel to the epithelium and cutting between the epithelium and the connective tissue. Once, thanks to the air coming from the suction, the base of the epithelium can be turned, can be separated from the underlying connective tissue. This is the time to change instrument and use the microsurgical scissors that are very, very good to follow the connective tissue surface. The microsurgical scissor is not good enough to cut between the epithelium and connective tissue. This can be done only with a blade. But once the connective tissue is exposed, you can place your microsurgical scissors and continue the desepithelialization towards the whole triangular tip is removed in one piece. So this is the second step, really critical for the advancing the flap, because now you have a surgical papilla that provides you, anatomic papilla that provides you a very, very nice vascularized connective tissue bed to the inner aspect of the surgical papilla, which also has connective tissue, less than possible. Here, you have to leave as much as possible connective tissue in the desepithelialization of the papilla, while at the level of the surgical, you have to give less connective tissue as possible, because this area will survive because of the connective tissue deriving from the anatomic desepithelize, and most of the connective tissue is left protecting the periosteum, protecting the bone. So this is the concept. Very, very thin surgical papilla, very, very thin surgical papilla. If you are not able to elevate a split thickness surgical papilla, you cannot make the coronally advanced flap. Now, independently on how big is the root exposure, here is more than 10 millimeters of root exposure, the coverage of this root depends on this first intention wound healing, surgical above anatomical, surgical above anatomical. So it is the very, very first wound healing from the inner aspect of the connective tissue of the surgical with the outer aspect of the desepithelialized anatomic papilla that will make the flap remain stable despite it has been advanced coronal for more than 10 millimeters. So it doesn't matter if I advance the flap 3 millimeters, 4 millimeters, or 10. It's always the same, the relationship, the vascular relationship between surgical and anatomical papilla. This is different from the tunnel, for example, because if you use the tunnel procedure and you have to advance the flap of 3 millimeters, yes, you can roll the papilla for 3 millimeters enough. But if it's 10, how can you roll the papilla for 10 millimeters? Not possible. Not possible. So the advancement of the flap in the middle is not more coronal than the cementoenamel junction, and you have to leave the graft exposed. Does it make sense to leave the graft exposed? It means that you don't know what happens to the graft. It means that you don't know what is the color. It means that you have to take a thick graft. Why? If you cover the graft, it doesn't make any difference if the flap is advanced 10, 6, or 5. What is important is that the movement of the papilla, the amount of millimeters that the papilla makes to reach the anatomical is the same of the flap in the middle. So what does it mean? It means that where we make our horizontal incision is far away from the tip of the papilla. That is exactly the same of the amount of the advancement of the flap in the middle. And we will measure this distance in order to have an advancement of the papilla of the same millimeters of the advancement of the flap in the middle. So the flap will reach the final position because of the first intention of wound healing interproximally. Sometimes the flap don't have keratinized tissue enough. So we will add a connective tissue graft, not because we want to cover with a connective tissue graft, but because we want to compensate the lack of keratinized tissue of the flap, which is made of alveolar mucosa with a good quality of connective tissue. How much connective tissue do we use? 4 millimeters only. It's the area where I would like to make keratinized tissue. I don't have keratinized tissue in the flap. I want to give keratinized tissue by applying the connective tissue graft only where I would like to have. If I don't have any keratinized tissue in my flap, my graft is placed 0.5 millimeter more coronal than the cementoenamel junction and 3 millimeters on the root. That's more than enough. I'm not using the graft to cover. I'm using the graft just to compensate the lack of keratinized tissue in the flap. But the whole remaining root is absolutely left not covered because it's not necessary to extend the graft apically because it is the flap that will be advanced, make everything heal by first intention, and covering the root independently on the depth of the recession. So the bigger, enormous difference between the tunnel and the coronally advanced flap is that the soft tissue margin that is displaced coronally is placed in this position, not because we pull it with a suture, we keep it with a suture, but the soft tissue margin will end in the final position, covering the cement enamel junction, thanks to the first intention wound healing closure, surgical above anatomical, because how much the papilla goes coronal is the same of how much the flap is going coronal in the middle. And this is completely independent on how deep is the recession. If the recession is 10 millimeter, I move the papilla 10 millimeter more coronal. If the recession is 4, I move the papilla 4 millimeters more coronal. While if you use the tunnel and the papilla is not elevated but only rolled to allow some advancement of the flap, this is a lot in relation to the depth of the recession. If the recession is very, very small, 2-3 millimeters, maybe you can place the flap coronal to the cement enamel junction in the middle by rolling the papilla, but if the recession is 5, 6, 7, 8, obviously there is no possibility to displace the flap in that position, and the only way you have is leaving the graft exposed. If you leave the graft exposed, the graft cannot be 4 millimeters, obviously, because it goes to necrosis immediately. So the graft must be bigger than the root exposure because you leave it exposed. So can we consider a minimally invasive procedure, a procedure that takes big graft, or can we consider a minimally invasive procedure, a procedure that as much as possible avoid the use of the graft, or maximum take a 4 millimeter size, 0.5 millimeters of graft? Since most of the pain, most of the post-operative course depends on the harvesting procedure, I think that today we can say that a minimally invasive procedure is a procedure that minimizes the need, the thickness, and the height of the connective tissue graft taken from the palate. Minimally invasive doesn't mean how much you advance the flap, because this is something that the patient don't know, and it's not influenced at all in the post-operative course. Minimally invasive procedure is to minimize the dimension of the connective tissue graft. Okay, now that we understood the concept, oh my God. Now that we understood the concept, I want to make the step-by-step of this surgical procedure, which should be performed following the general and biological rule I tried to tell you just now. I measure the recession in the middle because I want to measure how much I'm going to advance the flap in the middle. And how much I'm going to advance the flap in the middle is 1 millimeter more than the depth of the recession. So this is the first measurement that you have to take. Gingival recession plus 1. The same distance, gingival recession plus 1, is measured with a probe starting from the tip of the mesial and distal papilla. So you know exactly where to place your horizontal incision, which should be placed far away from the tip of the papilla, equal to the amount of flap advancement in the middle. And in order to be so precise, I make the same, just a small pressure with the probe on the tissue. So leaving the imprint of the probe there, I know exactly where to make the incision design with my blade. And this is done mesial and distal, same distance starting from the tip. Make a small pressure with the probe on the tissue so I can really repeat where is the position of the probe with my blade, my flap design, which is made of 2 horizontal and 2 vertical release incision. So the first incision are guided by the use of the probe in the exact position where I want to place, and they are done by using only the tip of the blade, so it gets inside the connective tissue less and possible until I can see the bleeding line. How large should this should be this horizontal incision? Theoretically, they should be 3 millimeters. Obviously, if there is space with respect to the adjacent teeth, I want to make 3 millimeters because I want to have a papilla that is so large that the vertical releasing incision can be really very, very limited in the divergency, but also in the length. So the apical corner dimension of the vertical releasing incision is not, as it was done in the past, 5, 6, 3 millimeters in alveolar mucosa. No, it's just to arrive where the submucosal tissue of the alveolar mucosa starts. And how do you know? Because when you cut at the level of the submucosal tissue, you have a different bleeding. So different bleeding means that when you cut the keratinized tissue, you have a bleeding line. Once you reach for the first time the alveolar mucosa, you see the drop of the bleeding. And when you see the drop of the bleeding for the first time, you don't have to go further apical. So by definition, the vertical releasing incision is extended apically once you reach for the first time the submucosal tissue of the alveolar mucosa that is much more vascularized, and you see a difference in the type of bleeding. So very, very limited vertical releasing incision, and this allows you, as you will see, to have a good advancement of the flap without the need to interrupt the flap at the level of the alveolar mucosa. That is the limiting factor of the vertical releasing incision. Now we make the second horizontal, 3 millimeters, and the second vertical, which is very, very limited in apical direction, just when you reach the submucosal tissue. Now, in this trapezoidal area, which is comprised by the horizontal incision and an imaginary line connecting the soft tissue margin to the vertical releasing incision, this is the area of the surgical papilla that we have already seen before, should be elevated split thickness, and now you know that I have to bevel the horizontal incision, I have to keep the blade parallel to the superficial tissue along the mesial aspect. Same thing at the level of the distal angle. So to turn the blade here, keep the blade as soon as possible parallel to the external surface. And once the blade can be kept parallel to the external surface, you have to reach the imaginary line connecting the most apical extension of the vertical releasing incision until the whole papilla split thickness elevated is capable to be turned spontaneously because of the mobility of the soft tissue margin where we have the probing pocket depth area. So this is papilla elevation, split thickness papilla elevation. And obviously this has to be repeated also for the second papilla because we want to have both papilla completely open before getting access to the most critical area, that is the soft tissue margin apical to the recession, where we don't have, in a case like this, any remaining keratinized tissue. But the elevation of the papilla follows the same rule. As soon as possible, the blade should be kept parallel to the external surface until an imaginary line connecting the soft tissue margin of the two adjacent teeth is reached. Second papilla elevation. Now it's time to elevate the flap in the middle. And in the middle, we never got with the blade because it's not necessary, because in this area, we have the probing pocket depth area of about 1 millimeter that helps us to place immediately, thanks to the probing pocket depth area, our periosteum elevator. This periosteum elevator will make a full thickness elevation of the flap in the middle, and I keep the periosteum elevator in contact to the root until I feel the overcanter of the buccal bone crest. And once the buccal bone crest is reached, I go more apical for a couple of millimeters, 2-3 millimeters more apical, in order to expose full thickness some of the bone where the buccal bone starts. And this is done for two reasons. First of all, because if you try to overcome the buccal bone crest with the blade, you risk to thin too much this tissue here that is already extremely thin. Second, if you go full thickness and expose a couple of millimeters of bone, full thickness apical to the recession, the inner aspect of the flap will also contain some periosteum. And some periosteum in the tissue apical to the recession is very important because this periosteum, this is the yellow area that was the periosteum removed from the bone, is the most vascularized tissue that will make the soft tissue margin more vascularized because the periosteum that is kept in the inner aspect of your flap. So the full thickness flap elevation is done only in the middle, very, very limited area, which is not including the area of the vertical release incision. And it has to be done for two reasons: keep the thickness of the tissue intact, and if it's possible, leave some periosteum in the inner aspect of the flap that makes much more vascularized, much more stable the tissue that has to be placed above the root, above the enamel, that is completely avascularized. So the full thickness elevation of the flap must be done until a couple of millimeters of bone are exposed apical to the buccal bone, only in the middle. Now it's time to go back to the area of the vertical release incision, apical to the surgical papilla area. And what is necessary now is to make a deep incision. This deep incision is done keeping the blade parallel to the bone in order to have the alveolar mucosa and the whole muscles of the alveolar mucosa separated from the periosteum. This is called deep incision. It's an incision, it's the only one in which the blade is kept in contact to the bone, separating the muscles of the alveolar mucosa from the periosteum. This deep incision is that one that we have to limit as much as possible, because when you go deep, parallel to the periosteum, there is big vessels and big nerve. And so when you cut deep apical, you risk to create a lot of bleeding, and also if there's nerve, like premolars, you can also damage some termination of the nerve. So the deep incision is very limited, and you can see that only the tip of the blade is used, and I go apically until I see that there is enough detachment of the muscles from the alveolar mucosa. This is the muscles. Few minutes ago, the muscles were completely attached. Look, when I was, first of all, you see the muscles is completely attached to the alveolar mucosa, to the periosteal bed, sorry. First, I start to see a certain thickness of some mucosal tissue. I go just a bit more apically in order to increase the separation of the muscles from the periosteum. And once the whole area of muscles have been separated from the periosteum, I can change the inclination of the blade and become as soon as possible superficial. You see that it's detached. When you see the alveolar mucosa detached, that's enough. You don't have to go even more apically than this. I will repeat you exactly the time when there is the detachment of the alveolar mucosa. You can see here now. Same thing on the other side. Parallel to the bone until you see the muscles. When you see the whole muscles separated from the periosteum, everything is completely separated and you can change. You see now everything is separated and the deep incision has been limited as much as possible. I can completely change the inclination of the blade, and instead of being parallel to the bone, I don't care about the bone anymore, but I just place the blade parallel to the external surface and remove the whole muscles from the inner aspect of the alveolar mucosa. It is this superficial incision that can be done very safely, checking, look, the movement of the blade from inside the tissue. And this alveolar mucosa is so elastic, so vascularized, that you can check the movement of the blade from inside until there is no more muscles inserting into the inner aspect of the alveolar mucosa. So these muscles that have been separated from the periosteum only in the most coronal aspect, and they have been separated completely from the alveolar mucosa, shrink apically and allow the alveolar mucosa to be advanced coronally. What is important is that the amount of alveolar mucosa you are going to free is a bit more mesial and a bit more distal than that one that is identified by the true vertical incision. So what you have to do with your blade is also to go a bit more mesial, like this, and a bit more distal with respect to where the flap is identified by the true vertical incision, in order to have this alveolar mucosa a bit more lateral mesial, lateral distal, to be used for the advancement of the flap, thanks to its elasticity, with no need to extend further the vertical incision. So while the deep incision is very limited, the minimum you can until you see the muscles separating and the alveolar mucosa capable to separate from the periosteal bed, the superficial incision is very, very extended in apical direction. The whole blade is inside the tissue, but it's also extended more mesial and more distal with respect to the area identified from the vertical incision, so to have alveolar mucosa completely free to be advanced coronally, even with no need to extend further the vertical incision. That is the key incision, superficial incision, where you check the movement of the blade from inside the tissue by transparency because of the very, very thin alveolar mucosa. And this is something that we will do during the hands-on treatment. It's very important to understand the difference between deep and superficial incision. This alveolar mucosa, it's so elastic that despite the vertical incision is very short, not extended to the alveolar mucosa, the alveolar mucosa that has been free a bit more mesial and more distal will give this typical shape that allows the advancement of the flap with no need to be extended further in apical direction. This alveolar mucosa, dear friends, is very thin. The alveolar mucosa, it's about 0.2, 0.3, no more, because the whole muscles, the whole submucosal tissue is completely left inside and separated with the superficial incision. Now it's time to make root planing. And again, root planing must be performed intrasurgically, not before, because if you make root planing before, you risk to traumatize the soft tissue margin. You risk to traumatize the papilla that must be left untouched in order to succeed with the coronary advanced flap procedure. So the intrasurgical root planing must be performed by calculating the amount of attachment loss. The amount of attachment loss at the buccal aspect is measured before starting the anesthesia. And it is done by adding the gingival recession plus the probing pocket depth apical to the recession. So what you have to do before surgery is to measure, starting from the cement enamel junction, the distance from the cement enamel junction to the soft tissue margin, plus the distance from the soft tissue margin to the tip of the probe inserted into the sulcus. Then, intrasurgically, the same distance is measured, that is the amount of clinical attachment loss before surgery, is measured starting from the cement enamel junction in apical direction. And you will see that almost ever the tip of the probe reaches the buccal bone. It means that from the level of attachment to the level of the bone, there is still an area where there was connective tissue fibers inserted that it was not probable before anesthesia, and this area must be respected from root planing surgical procedure. So now I know that the last 1.5 millimeters must not be planned. So I use the Mini 5 curettes. It's curette with let's say, working hands, very, very small. we turn the end of the curette in order to keep the same convexity or concavity. We don't want to change the shape of the root. It's a mistake to flatten the root. I will tell you why in a few minutes. What is important from a clinical point of view is that the root that we are preparing is really very, very hard, smooth. And most of the time we recognize that the root is ready from the noise the very sharp curette makes when the root is prepared. In the beginning, we use the curette, but a lot of materials of the root is removed because it's very demineralized, while as much as we continue to make root planing, the noise coming from the dentin becomes the typical credentinaire of the nice dentin. And once the noise and the feeling with the curettes is that one of the healthy dentin, not demineralized, not soft, this is the time to stop to make root planing. But this root planing also creates a lot of smear layer that accumulates inside the dentin tubuli that are exposed once the demineralized and soft dentin has been completely removed. So the objective of root planing is to expose good quality of dentin with a lot of dentin tubuli completely exposed. But it's also true that this root planing creates smear layer that accumulates inside the dentin tubuli, which has just been exposed thanks to the root planing. And so we also have to remove the smear layer from the dentin tubuli, because the objective of the chemical treatment of the root is to promote blood clot adhesion. Blood clot adhesion is an interaction between the fibrin net of the blood clot with the fibrils content of the dentin tubuli. It's really this perpendicular interaction between fibrin net and fibrils, collagen fibrils of the dentin tubuli, that will make blood clot adhesion perpendicular to the root. And blood clot adhesion is the biological mean to block epithelium downgrowth. So if we don't want to have healing between the soft tissue and the root, characterized by junctional epithelium, but we want to promote connective disattachment again, like it was before, having gingival recession, we have to block epithelium downgrowth. Epithelium downgrowth is blocked by promoting blood clot adhesion, namely interaction between fibrin net, so we have to give great stability to the blood clot, and exposure and interaction of the blood clot fibers with the fibrils, collagen fibrils of the dentin tubuli. So this is called surgical stability. What does it mean, surgical stability? It means that at the end of the surgery, when we see the patient and when we leave the patient, we don't have to see any area through which the blood can get out. Obviously, because we want to have blood accumulating perfectly between the soft tissue and the root with no possibility to the blood to get out. And this is done laterally, easily, because we have very, very short vertical incision that is not extending in the alveolar mucosa. So apical, the flap is like an envelope type of flap, and the whole blood is taken to the area of the pedicle from the lateral aspect. In the area of the pedicle, laterally, the flap is closed by first intention wound healing along the vertical incision, but also coronally, everything is closed by the first intention wound healing, surgical and anatomical papilla, which is the only weak point. The only weak point is where the tissue of the flap adapt to the enamel. Yes or no? In this area, or composite restoration if it was done before. In this area, obviously, there is no way to achieve first intention wound healing. And so it's the very, 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 very tight adaptation, tight, no space between the soft tissue margin and the convexity of the enamel of composite restoration that don't allow the blood coming from the pedicle to get out. And this adaptation, very tight, it's achieved with the suture that we will call sling suture that turn twice around the palatal aspect and keeps the tissue very, very in tension, tight against the convex shape of the enamel. So at the end of the surgery, you have to move the lip of your patient, and despite the whole movement you make, you should not see any blood seeping from the soft tissue margin. This is called surgical stability, and this is the first step to create blood clot between the soft tissue and the root. Then, if you did root planing correctly, if you applied ADTA 24%, leaving it for 2 minutes on the root, you also remove the whole smear layer accumulating inside the dentin tubuli, and you are promoting the best of blood clot adhesion. So after root planing, you apply this gel. This is ADTA, 24%, and this is left in situ for 2 minutes so that the old remnants, the old smear layer, which accumulates inside the dentin tubuli, can be removed. After these 2 minutes, the ADTA must be rinsed with a lot of saline not to leave any remnants of ADTA inside the dentin tubuli. Now, we have also to think as much as possible from a biological point of view. Which kind of attachment we will form between the soft tissue and the exposed root? 2 possibilities. Junctional epithelium, if it wins, or if we block junctional epithelium to rebound apically, it is the cells of the periodontal ligament, which is all around, yes, that can colonize blood clot. And once it is the cells of the periodontal ligament all around that colonize the blood clot, this blood clot can be transformed in new cementum, new connective tissue fibers, and theoretically also new bone, because it's totipotential, the cells coming from the periodontal ligament. But obviously, we cannot have new bone because the root is placed outside of the bone. And so we cannot create bone if the root is placed outside. If we want to have bone, theoretically, you have to ask your orthodontist to place the root in palatal aspect, and so you can also create bone. But since the root is placed outside, the only thing that the periodontal ligament can create is new cementum. And the soft tissue can insert into the new cementum with collagen fibers inserted perpendicularly. This is called new connective tissue attachment. New cementum formation and new connective tissue fibers inserted perpendicularly. That is exactly the same quality of attachment that was present this morning, remember, in the suprabony component of the root. So this is called restitutio ad integrum. Restitutio ad integrum after mucogingival surgery is not new bone. Yes or not? Restitutio ad integrum in mucogingival surgery means new connective tissue attachment again. So connective tissue fibers inserted perpendicularly in the root cementum. And we have to promote this. We don't have to do so much because it's in the capability of the periodontal ligament cells to produce new cementum and new attachment. But the problem is that we are in the patient mouth. There is a lot of trauma, there is a lot of bacteria. So now we want to promote cells of the periodontal ligament to colonize the blood clot instead of epithelium. The epithelium is blocked. Remember how? Advance the flap on the enamel as much as possible and achieve blood clot adhesion between the fibrin net and the collagen fibrils of the dentin tubuli. So the problem of the epithelium is blocked, and now we need time, we leave time for the periodontal ligament cells to colonize. It's obvious that the larger is the root, yes? When we have very, very large root or very, very prominent root, the distance that the periodontal ligament cells have to do to colonize the entire root is longer. The narrower is the root, the more easy for the periodontal ligament to colonize, the wider and the more prominent is the root, the longer is the trip the periodontal ligament cells have to do to cover the whole root exposure. And so when you have a very prominent root, there is the indication not to flat as it was done in the past, but to add amelogenins. What is amelogenins? It's proteins that applied on the root promote cells of the blood clot to be differentiated in cementoblast, fibroblast, and osteoblast. And when there is, at least from a biological point of view, the indication to use amelogenins is when you have very, very wide buccally displaced root. And so in this case, we want to help the cells of the periodontal ligament by inducing the cells of the blood clot to be transformed in cementoblast and fibroblast and produce new connective tissue attachment. So when you have a prominent root, typical of the upper canine, typical of the lower post-orthodontic gingival recession, typical of the upper molar, where the root is very prominent, this is the main indication to use amelogenins together with the surgical procedure. And these amelogenins is not something we use to improve root coverage, it's not something we use to increase the keratinized tissue, it's not something we use to increase the thickness of the tissue. Maybe they have also an influence in root covering or in the keratinization of the epithelium, but the most important reason why we add the use of amelogenins to the surgical procedure is to promote the best quality of attachment between the soft tissue and the root, especially in very, very prominent and wide root exposure. These amelogenins are applied with a gel, 1 minute left in situ, so that there is time and place for the gel to deposit the protein at the level of the dentin tubuli. Now we prepare the vascular bed for the surgical papilla, and this is done, as we already see, by desepithelializing the anatomic papilla, and this is done first, sign the area, place the blade, new blade, parallel to the external surface, cutting between the epithelium and connective tissue until the suction of your assistant promote the turning up of the epithelial layer. And now it's time to change the instrument and to use the microsurgical scissors to cut between the epithelium and the connective tissue to reach the most coronal tip of the papilla that can be absolutely well desepithelized by the most recent type of microsurgical scissors. Tomorrow you will have the opportunity to see the new one that has such a small tip that are able also to desepithelize the smallest angle of the surgical papilla. Obviously, this is scissors that you have to use only for the desepithelization of the papilla. You don't have to use for suture removal or for any other objective than the desepithelization of this papilla. Now the epithelium is separated. You see, I keep it with the suction, and you see until the most coronal angle is reached, you follow the connective tissue surface until the whole triangular is completely desepithelized. Now, theoretically, everything is ready for the flap to be advanced. But we know that there was no keratinized tissue at all in this flap. So the risk is that in such a prominent root, in such an avascular area, we have collapse of the alveolar mucosa to the root, and so we don't gain thickness. We have shrinkage of the flap because we don't have the good stable tissue that is called keratinized. How can we do to compensate the lack of keratinized tissue? We will add a connective tissue graft whose mesial distal length is 6 millimeters longer than the width, because I want to extend the connective tissue graft to the base of the papilla for two reasons. First of all, it's easy to apply, it's easy to suture, and second, I also increase the thickness of the papilla that also promote growing with time, thanks to the increase in the thickness. While the apical corner dimension is 4, independently how deep is the root exposure, because I'm using keratinized tissue only where keratinized tissue is critical, not apical. Apical, there is no patient that has 8, 9, 10 millimeters of keratinized tissue. This is an horse, it's not a patient. So the amount of keratinized tissue is that one I need to give good aesthetics and good function. And this amount of keratinized tissue that, from a clinical point of view, has been judged to be adequate is 4 millimeters. Most probably 3 would be enough, but 3 is more difficult to handle, is more difficult to desepithelize, is more difficult to suture. So 4 is the good compromise from a clinical point of view, and also for the patient point of view. If you take 3 millimeters height graft from the palate, or 4, nothing changed. While if you take 5, 6, 7, this change a lot, the post-operative course. So the best compromise today is to take a free gingival graft that will be desepitalized extraorally with a apical corner dimension that is 4 millimeters, independently on how deep is the gingival recession and whose thickness is less than 1 millimeter.